Hello, everyone. We're going to get started with the panel question and answer series. So hopefully everyone had a chance to take a short break. And this is the part of the symposium where we really want to get to the questions that you have. And so we've tried to collect all the index cards. We're not going to be able to get to all of them, of course. And actually, interestingly enough, there was quite a few that had very similar questions. And so I think it's a really good part, right? You all have similar issues that you're dealing with, have similar questions and similar themes. So hopefully we can address the majority of them here today. And certainly if you have additional questions, we'll try to stay afterwards and talk with you or talk with your doctor, of course. That's why we're here. But we have the advantage of having a distinguished panel of experts here to my right, to your left, to help us answer our questions. Here we have, all of these people have already given presentations, so I won't introduce them at length, but Dr. Torres, our functional neurosurgeon, Dr. Espe, physician, Maureen Gartner, a nurse practitioner. Actually, Maureen, you didn't give a lecture this year. We didn't make you give a lecture. Dr. Kara Jacob, physician, Sarah Palmer, exercise extraordinaire, and Kim Saruji, basic scientist. So I thought we would start off the beginning with, I thought this was a really good question, and I'm going to direct it to Dr. Espe. Doctors often say that Parkinson's is not inherited, but it sure seems to run in some families. Can you explain that a little bit? And what is our current understanding about the hereditability of Parkinson's and the genetics of Parkinson's? We don't know everything, of course, but yeah.
Yeah, absolutely. That's an important question. It goes to the core of the dissonance about which we discussed earlier. Parkinson's can be genetic in some individuals. In fact, some individuals can have a gene that when mutated will lead to a type of Parkinson's. Others have Parkinson's that may look like the individual who has a gene mutation without a mutation. What's most interesting is that in the same families, and what gives complexity to this, you can have a gene that gives rise to Parkinson's of different types, and sometimes to other conditions, and sometimes to nothing at all that we can identify. We used to believe that if you had a gene mutation, you would have a disease. And the most common of all Parkinson's genes, LRRK2, is one that, in fact, has low penetrance. If you have a LRRK2 mutation, you have 7 times out of 10 chances of not having Parkinson's. So it's actually more likely not to have Parkinson's. And if you do, it may not look anything like classic Parkinson's, can be very different. And interestingly, you can have LRRK2 Parkinson's, and on autopsy, no Lewy bodies. It's been demonstrated that Lewy bodies aren't present. And by the way, that's the concept that we are now advocating, that in fact, when you look at all the data on Lewy bodies, Lewy pathology, turns out that alpha-synuclein aggregation is neither necessary nor sufficient for Parkinsonism or degeneration to occur.
Okay. Thank you. So another question that many people had was about deep brain stimulation surgery. There were a number of questions about kind of the logistics of deep brain stimulation surgery. Is it covered by insurance? How much does it cost? Dr. Torres, could you comment a little bit about that?
Yeah, so for Parkinson's disease, as long as the patient meets the criteria, like I mentioned in my talk, if it is classic Parkinson's and we find that the patient is a good candidate, meeting every other criteria, insurance will definitely pay for it. There are certain things that we need to meet, i.e. that the scaling and the measurement by the UPDRS, many insurances will say, I need to see those numbers in the off-state, the on-state, and sometimes they want to know exactly what device we're going to place, and basically we work around different companies if they have one approved versus another one. But in general, it is approved. Cost of the whole thing, to be honest with you, I don't know. I can tell you it's not something you want to pay off your pocket. The battery alone for one of those devices can cost $20,000. That gives you a sense. So the reality of it is, no, patients do not pay for the procedure. You will have obviously your regular normal deductibles that you have for your insurance. Hence the reason why my Christmas time and after Thanksgiving becomes very busy, because everybody has met their insurance criteria for something else, and then they say, you know what, this is perfect. I can do my DBS now because I don't have to pay anything. And indeed, we try to accommodate them if that's the case. So.
Yeah, and there's actually been studies looking at the cost effectiveness of DBS, because it's not just that you're spending all this money, it's what are the benefits that you're getting. And so in the right patient, and someone who's a good candidate for DBS, DBS can be cost effective because it reduces the amount of medications a person can take, it can reduce the amount of complications that they can experience, and so that's an important part of the equation. But it is an expensive therapy, and so it's something that you have to think about. But it is covered by insurance, absolutely. All right, Sarah, I had a question that I thought you might be able to at least give us your opinion on. There was a question about whether there are benefits in Parkinson's disease for things like medical massage or healing touch or other sort of alternative kind of therapies for Parkinson's disease. Any experience with those or comments on that?
In the alternative medicine, obviously that's not my realm, massage and things like that, but I go to a lot of talks and things, and I think for anyone on the massage end that it can be very therapeutic. I think of massage as therapy, not as some fluffy thing people do just to get a massage. And people with stiffness and rigidity in their muscles and joints, it can be very beneficial. So I would try to find someone that's very qualified, that maybe already has some patients with Parkinson's or does some people that have some neurological issues. So just trying to find a qualified massage therapist. Did I answer that?
Yeah. Any comments from the other providers, people that they've had experience with their patients that have done massage or anything like that? I would echo your comments. I think that I've had patients that find that it's helpful. It's certainly not harmful, and it's a way to help with stretching and rigidity and things like that. So, okay. Another question was about, I bring this up because we did talk about it, but I think there are going to be varying degrees, and so for a panel discussion, there's varying opinions on this. So the question is it better to take Sinemet on an empty stomach, or do you need to strictly follow the 30 minutes before, 60 minutes after rule? So Maureen, actually Kara, I think first, and then Maureen and Albert. I'm curious as to what each person's individual opinion is on that.
So I tailor this somewhat to the patient, right? What I don't ever do is start out making people so stressed out about when they're going to take this medicine and when they're going to eat. And so I say to them, as a general rule, you want to try to take it away from food if possible, especially if it's, a higher protein meal you're going to eat. That being said, I've had patients come to me and they say, I'm so stressed out, I have to take this medicine 5 times a day, and I don't know when I'm going to eat, and if we're traveling, it's very hard. And I ask them, well, do you ever notice a difference in your medicine when you've been taking it around the time of food or not? And if they say no, I say, then don't stress out about that. We have patients that seem to be a lot more sensitive to this problem. So if you're one of those patients that really notices that their medicine doesn't kick in when they take it around food, I say those patients oftentimes are more strict about when they eat, right? So it's almost like they self-modulate, this problem. So again, I think as a general rule, it's important to remember, but again, I always say don't let it ruin your social life if you're out eating. That's my take, but
Yeah.
I don't know if anybody feels differently.
Okay. Any other thoughts on that? I mean, I just know that varying physicians are stricter in their recommendations for that. So I think, moderation I think is important. You can't schedule your life down to the minute. Life happens. That said, it is important to take your medication on time. So you have to find that delicate balance. So I think that's a good point. Dr. Suruji, there was a question on what is the update or the most recent knowledge, if there is any, on stem cells in Parkinson's disease? It's always a hot topic, and so it's one of the areas where there's been some changes over the years as to how much we think this is going to play a role in the treatment of Parkinson's to come.
Right.
Well, I think the good news is that it's up and coming, right? There's a lot of research on it, a lot of good research being done. The bad news is that we're not there yet. All right, so the theory is that you can take a cell, say from your skin or from the skin of a Parkinson patient or from a normal patient, and you can then engineer it using various chemicals and factors and that to turn into, say, a dopamine cell. And then you place that back in the brain, and or you place a lot of them back in the brain, and that will replace the dopamine that's missing, right? That's one avenue. But there are a lot of issues, and for example, if you put them in the brain, will it create a tumor? Will they start dividing uncontrollably, right? So a lot of that has not been worked out yet. But there are studies. I reported on one last year in non-human primates. There are studies that have gotten good results with stem cells. You may have heard also stem cells derived from your fat cells, for example, and a lot of these clinics have popped up, I think, all over the country, not just for Parkinson's, but not just for Parkinson's, and for other things like eye diseases, for example. And you might have heard in the news there was a report. There's a clinic now that's, I think, being investigated, where they took fat cells and then injected them in the eye of some people with, was it macular degeneration? Yeah. And it made it worse. They went blind, right? But a lot of these clinics, if you see them online or advertised in magazines, they're unregulated, right? So if you're looking for stem cells, you have to wait a little bit, and you have to make sure that it's FDA approved, they've gone through clinical trials, and everything. So I guess, I mean, it's promising, but we're not there yet, in my opinion.
Yeah, Dr. Espay.
Just a comment. There are two questions that are critical for us to answer. One is what? That applies to treatments. Stem cell therapy would be a what. The other one is such critical question is the who. And I hope if no other message came through from this session earlier today is that there will never be a therapy for everyone that has Parkinson's disease equally effective, or in fact even effective at all. The therapies we have for common denominators can only treat symptoms. And we're doing great, but we need to treat diseases. If anybody tells you that they have a disease that cures Parkinson's, and many stem cell therapy providers claim so in other countries where you can do medical tourism, be very skeptical. You have a higher chance of being harmed, and any improvements you might have will be mediated by what Dr. Duker mentioned, the remarkable placebo effect we all can harness potentially by believing in the virtues of a therapy.
Okay. Thank you both. Maureen, I know that we take care of a lot of patients who have some confusion at night, sometimes called sundowners in colloquial. There was a question as to, is that typical of Parkinson's disease? And if so, what are some of the ways that we can help to treat that?
Okay, I don't think it's typical of Parkinson's disease. Did I answer that right?
Oh, yeah. It can be...
We certainly have a lot of patients with it, but
yeah.
Don't everybody be afraid. You're going to get sundowners, okay? So what is sundowner syndrome? That's when someone becomes more confused in the late afternoon and evening. So how do we treat it? There's no magic way, number one, just like everything else. Number two, sometimes you want to lighten up the rooms and have more light because it tends to happen as the evening sets in. Some people have treated it with an antipsychotic in the afternoon if that person really gets severely hallucinogenic, seeing hallucinations, very irritable and hard to deal with. That's another avenue of treatment.
Okay. All right.
Anything
no, I think
else?
that's appropriate. No, I agree. No, it's a part of the disease that certainly doesn't happen to everyone, but there are treatments available for it. Dr. Jacob, there was a question about how to diagnose Parkinson's disease and whether what is the best way to diagnose Parkinson's disease, and what is their benefits in terms of MRI scans and DET scans and things like that? What's your opinion on that?
So still, as of now, the best way to diagnose Parkinson's disease, although how we're thinking about Parkinson's disease is totally changing, is a clinical diagnosis, right? So we have to look at the core clinical features of Parkinson's. So slowness to movement or bradykinesia, rigidity, tremor, resting tremor, particularly postural instability. So those are kind of the core features of Parkinson's. So when we're looking at a patient, we're looking for those things plus other kind of factors that point in that direction. So loss of smell, constipation, those other features that we may associate with Parkinson's. So we look at that to make a diagnosis on your exam, your clinical exam, and then we're looking at other features that may suggest maybe an atypical form of Parkinson's. So again, we usually, the kind of gold standard way currently to diagnose Parkinson's is through a clinical evaluation. Now, there are some supplemental tests that we may order if that diagnosis is in question, or again, if we're looking for atypical forms of Parkinson's, and that's where imaging like an MRI may be helpful, or even a DAT scan, this is a dopamine uptake scan, may be helpful. But the general answer would be it's a clinical diagnosis by a movement disorder trained neurologist in general. Or a general neurologist too can diagnose Parkinson's, but yeah, it's a clinical exam.
Right. Sarah, with respect to exercise in Parkinson's disease, this is a question that we get pretty often actually, is what is the best form of exercise in Parkinson's disease? Is there a best form of exercise in Parkinson's?
Well, the research shows, and I try to look at what research is showing is most beneficial for people with Parkinson's. So the research shows that intensity and amplitude are what helps the brain. So we want to do exercise that helps create brain change, or the fancy word is neuroplasticity. So if whatever you're doing, if you're doing it in an intense manner, and that's a different definition for each person, and doing it amplitude or as big as you can. And then there's also, on top of that, some Parkinson's-specific exercises that you saw up here today that help combat those symptoms. So doing things that help combat your stoop posture, if you have gait issues, working on your gait. So you can apply that to many things. So for example, boxing is very popular today. We do it, a lot of people do it. And it's not that necessarily boxing is the end all, it's just that the elements that you work on for boxing happen to be motor symptoms that are affected at Parkinson's. So, quickness and agility and some cognitive elements, so that applies to boxing well, but it also can be applied to dancing or many number of things. But if you like to do tennis or pickleball or whatever you like to do, as long as you want to maintain what you're doing and if it's still safe, but also, so aerobic exercise with some skill acquisition is also very highly regarded to help create that brain change. So you want to make sure you get in your cardiovascular exercise. And research has shown that with people with Parkinson's, someone that does 7 days a week of exercise had significant better improvement than someone that did 5 or 6 days of exercise a week. So it kind of shows that if you're doing something every day, and that was mostly aerobic exercise in that study, so it's really as much as you can do, get in your aerobic exercise, and also try to add some intensity or some intervals with that in whatever way, and to add in some Parkinson-specific exercise with that. But that can be in many different types of exercise.
Dr. Sergi, did you have a comment?
Yeah, I thought I'd like to add something. I mean, there's some underlying biology from what Sarah described, the benefits of exercise and neuroplasticity in the brain, because research has shown that exercise can stimulate the production of what's called neurotrophic factors, or growth factors in the brain. And these are naturally occurring chemicals that improve the health of neurons. They repair them after their neurons are damaged in the brain. And with exercise and intense exercise, it can increase the expression of these beneficial factors, growth factors in the brain in motor areas related to motor movement, and also in cognitive areas, an area called the hippocampus, you may have heard. Anyways, that's involved in learning and memory in that, so that's associated with improved cognition. So again, that's one of the underlying benefits of exercise. There's actually been shown there is upregulation of these beneficial growth factors in the brain.
Okay, thank you. Well, so there are so many questions that we had. I'm going to go, the last question, I think probably there was a number of different aspects to this question that a couple people had raised, but this is for Dr. Espay. There was a question about orthostatic hypotension in Parkinson's disease, and is it a disease of its own? Is it part of Parkinson's disease? What percentage of people have orthostatic hypotension in Parkinson's disease? And what are some of the treatments for that? So it's a lot of things, but I think that they all kind of go around the same theme.
Great question. In fact, it is what we consider one of the low-hanging fruits for therapeutic development because it is so common. Orthostatic hypotension is defined as the drop in blood pressure when we go from sitting to standing or lying to standing. And that relates to a difficulty with essentially making the changes in the vessels that would be necessary to ensure that we adjust for gravity. If we're farther away from the ground when we're standing, gravity is, of course, a greater force and requires the blood pressure to be increased a little bit to sustain that. So the capacity of the autonomic system, this is the part of the nervous system that regulates automatic types of activities, breathing, pulse, blood pressure, sweating, etc., is affected to an extent that it then does away with the ability to regulate the changes in the constriction of the vessels and the pressure that the heart needs to make to compensate for those changes. What happens then is the blood pressure is lower, that meets criteria for orthostatic hypotension, and the brain doesn't get the oxygenation and nutrients for periods of time because it cannot compensate for that drop in systemic blood pressure. The question we ask at the clinic is, when you stand up, are you lightheaded? And 40% of individuals that would have a drop will not say they are lightheaded. If they are, then that gives it away. We say, oh, that's probably the blood pressure. For the 40% that say, no, I'm fine, I don't think that there is any lightheadedness, yet they do have a drop in blood pressure. That's called asymptomatic orthostatic hypotension, only because lightheadedness isn't endorsed. But it turns out that we've identified that these are people having difficulty with thinking and memory, feeling foggy-minded, feeling that they are unsteady, freezing episodes, and falls. And it turns out that it doesn't matter whether you can recognize lightheadedness or not. If the blood pressure is dropping, you're going to have an equal set of problems to those who do endorse lightheadedness. It is possible that it isn't endorsed because over a period of time, the brain is compensating for this. So when we see it now, we recognize that just by altering the blood pressure alone, by preventing the drops, and perhaps magnifying the periods in which the blood pressure is higher than normal, the quality of life increases dramatically. People who have foggy-mindedness feel much more with it. Falls reduced, freezing episodes come down. So of all the strategies that we have to deal with many issues in Parkinson's, this one is one that's often unrecognized and quite a few times undertreated or untreated. And two of the research programs that the Sunflower Rev It Up funding was able to help us cover relate to the improvement of the recognition and treatment of this particular problem. And I think that the opportunities are quite large to do so.
Very good. Well, I want to thank our panel again for their expertise, their time, and answering your questions. I know we couldn't get to all of them, but really some excellent questions here. And I think overall this has been a great day. I think it's really given us a lot of good information, a way to learn more about Parkinson's and a way to live better with Parkinson's disease. The last thing, Dr. Shruji and I are the clinical directors or the course directors. We just wanted to make sure that you see on the folder there are evaluation forms available online. We really would like your feedback. It helps us improve this year over year. If there are ways that we can do this better, that's what we want to know. If you want to tell us we did a good job, that's fine too, but tell us also a way that we can improve on it so that we can make it better and better each year. But really want to thank you all for coming out and giving of your time and giving of your energy here today. Thank you.
Thank you.